half the time.
All right. So let's see. You guys
Oh,
can see the screen just fine?
yeah.
Yeah, okay, cool. Okay. So this whole brain, eyes, all that stuff. Um, some of this stuff I kind of just filled out and we're just talk through it. But I want to get through like the most important parts through. So I think some of the most important stuff here is definitely going to be your meningitis. So we're going to go into a bit more detail with that. I kind of already have written out here the definition of your meningitis. It's your inflammation of the meninges. It surrounds the brain, spinal cord, and here's like a anatomy picture if you like anatomy, if that helps you. The meninges here is composed of these little things. It has cerebral spinal fluid running through it, and this is an inflammation of one of these layers. I think it's typically the arachnoid or the pia mater, but that doesn't really matter. There is a definition. Um, sorry, there is a difference between viral and bacterial. So typically, the viral meningitis is going to be more self-limiting, meaning you're able to make more of a complete recovery and doesn't need the same level of attention as bacterial, as well as viral being able to do standard precautions, so just your gloves. Um, Bacterial, though, is life-threatening and it's also highly contagious. And this one utilizes droplet precautions and kind of like what we were talking about. Iggy says to use surgical mask and gloves. That's what that means there for the meningitis for the droplet. And what Kaylin was mentioning is someone kind of comes in and I guess they're waiting for like a full diagnosis on if it is bacterial versus viral, then they would probably just make the assumption or just gonna be like, it could be bacterial, so we'll be in droplet precautions until we can rule out. So maybe in clinical, you might have had like a patient that they were being ruled out for MRSA, so just because I think all of them have to be kind of ruled out for it at some point or like ruled out for C. diff. So they were, even if the patient would have ended up being ruled out for it, in the meantime, they were like on contact precautions. So maybe you've seen something like that. Yeah, so Kaylin says coming in from a sniff, you get the MRSA nair swab and the patient is considered contact precautions until they get ruled out. Even if they might not have any like outward symptoms, they would just get ruled out. So in the same case, if someone comes in and it's looking like it could be meningitis through maybe some of the signs and symptoms, I think that's that's pretty like universal. Then they would probably put them in droplet for the meantime until they know for sure. Okay, so that's kind of the general um, pathoanatomy of it. So the main thing you really want to think about is going to be your cerebral spinal fluid. There's a difference between bacterial and viral when it comes to that. Uh, and how is that diagnosed or how are they able to analyze that? What's the thing called? Pretty much like a culture of the cerebral spinal fluid. There's a specific name for the procedure that it's called when they actually get it out. Yeah, the lumbar puncture. So that's one of your diagnostics. And so what you guys should be able to know is like the difference, like the main key differences between viral and bacterial that you can get from your lumbar puncture or from just kind of looking at it. So bacterial, what are some things you'll encounter with your bacterial? Yeah, it's going to be cloudy. The cerebral spinal fluid will be cloudy. What about actual analysis of your cerebral spinal fluid? So they usually look at glucose as well as kind of like the proteins. How would that look? Yeah, it's going to be a low glucose. So I like to think of it kind of like the bacteria. Remember the bacteria like environments. where they can thrive. So glucose, the bacteria, just kind of imagine the bacteria is in there and kind of eating up all the little glucose. So your glucose level in your cerebral spinal fluid is lower. And the value for this is not the same as your serum. It's a different one, but I don't think the you really need to know that. And then meanwhile, your proteins, I believe that's due to inflammation. So kind of like when we were talking about inflammation in your renal patients, they have that capillary leakage leading to proteins leaking out into the urine. Um, Here you kind of have the inflammation causing proteins to start leaking into the cerebral spinal fluid. So that's why that is how it is. So that's your main key differences. There's going to be a few other things with your cerebral spinal fluid, but these are the main ones that you really need to know. So then, kind of in contrast, yeah, like Kaylin said, diabetics have a worse time with infections because of how much sugar is going through um, the circulation. So what about the for the viral, how does the cerebral spinal fluid look? How does the glucose? How does the protein look? It's going to be clear, so it's not really going to be um, cloudy like the bacterial. Think about kind of like your urine. Your urine will be cloudy, can be cloudy if there's like a UTI or something. Yeah, the sugar will be like a normal level. Your viral's not really chomping on the glucose as much. And yeah, the protein will be mildly elevated. So the amount of inflammation isn't going to be as bad compared to the bacterial, because remember the bacterial is much more severe. Your body's able to fight against the viral a lot better. So the inflammation is less severe, so there's less leakage of your protein. So that's important for you guys to be able to differentiate. And in general, yeah, you will have increased white blood cell count for both. I think it's also in the cerebral spinal fluid, but this is the main differences that I think you guys should really know. So, what are some general signs and symptoms? So there's like a few key signs, manifestations of your meningitis that I think you guys should be able to tell. Like if you hear it in a question, you see it, you should be able to immediately kind of start thinking about your meningitis. Yeah, the stiff neck pain, specifically, they call that nuchal rigidity. So if you see this phrasing on a test, oh, Kaylin, my bad. We don't have time, girl. We are limited for time. Although technically, I guess today I could go longer than 3, because the Student Success Center closes later. But I also need to study for my own test, so we'll try to end it at 3. Oops.
I was like, for me, this is actually helping me study too, so this works out well. But I have a question session at 5, so
Yeah.
as
So
close to 3 as we can get.
yeah, so that's the nuchal rigidity. That's a stiff neck pain. What else are some things that you can expect with an infection like meningitis? Someone already said increased white blood cell count, so I'll just add that in here. Yeah, you can have fever and stuff. The headache is also an important one. Headache, I guess someone hasn't mentioned the other one. There's like another one um you might think about. So headache makes sense. Just you have increased pressure in your headpiece. Um, what else might you have? So there's like a specific word I'm kind of looking for. You guys can cluster the word headache with like a few other ones. ICP, yeah. So we have an increased ICP. So that's intracranial pressure. So kind of in the name, pressure inside the brain or inside the head, inside your cranium, intracranial pressure. And that will come with some headache. And then there's another sign and symptom that can be really big with increased cranial pressure. I'll see if you guys eventually mention it. Sebastian mentioned Yeah, vomiting, exactly. So nausea, vomiting is a big one. Specifically, like even like projectile vomiting can be a good one. Yeah, altered level of consciousness is going to be one of your first signs and symptoms of increased ICP. Someone already mentioned photosensitivity, so that's good. Anything else you guys can think about? Let's see. Someone already mentioned, yeah, fever's already kind of here. Let me see. Let me look back at your answers. My chat is kind of small. Let me see. Ba-ba-ba. Yeah, there's like a little thing called your Kernig's and then your Brunski's sign. I kind of just have a picture for it. I think it's a lot easier to just look at the picture than try to explain it in words for the signs. And I believe your Kernig's sign is not the most reliable one, but your Brunski's can kind of show you that there's some um increased ICP. Like you kind of have with the Brunski's sign, you move their head up, do like a passive flexion of the neck, like it says here, and it causes them to flex their hip and knee, kind of like towards the core. While Kernig,
I'm gonna stop you right there real quick. It's a sign of the meningeal irritation and swelling, meningitis specifically.
okay.
You mentioned it was for ICP.
Oh, okay. That's what
I
I.
just wanted to clarify that. And
Oh,
then
okay.
I saw Anne and Edgar put down hypertension and bradycardia. I was talking about the Cushing's triad a little bit yesterday.
Oh, okay. You talked to them about that.
I did. So I think that's what they're referring to as well. Those are like the big bad signs. So I don't want to see bradycardia. We're pushing down on the brainstem too much. Hypertension, specifically systolic, your top number being elevated. Definitely don't want to see that one.
Yeah,
And then the weird breathing. But yeah.
yeah.
So
That's stuff that they don't really talk about here. So, but yeah, that's a thing that we learn in 240. That's like your big kind of sign of poor prognosis. I don't want to, well, I guess I'll include it, but you don't need to know it. But specifically like high systolic blood pressure, bradycardia, irregular breathing. So, um, think about if you remember from 210, your Shaney-Stokes breathing, that's a potential thing that could be happening with increased ICP, which is poor prognosis because I think they taught that one in like the post-mortem care part. So that is like a really bad sign. So let's see. So basically, Kaylin, you're saying I should put this more like this, more like that.
yeah, it's under your signs and symptoms. I just wanted to clarify that because I actually came across a question earlier today about this, and it was
Mm,
saying like, "What is this a sign of?" And I put increased ICP, and it was like, no, it's meningitis because it's specifically like
mm.
that's a specific sign for it. So
Okay, that's good to know. Okay, that's pretty good. Are there any other diagnostics you guys might want to look at other than the lumbar puncture? And what else about the lumbar puncture might you guys want to kind of work through? So there's some like things to do with the lumbar puncture. Yeah, those are all pretty good. What positioning do you want them to be after a lumbar puncture? Yeah, that's a good question from Kaylin to Lori there. What does a CSF leakage look like? You'll kind of add that here. Yeah, so you get, yeah, like the halo bullseye. Let me see if I can find a good picture of that. Hopefully I have it. Kaylin, could you find a picture of it if you don't mind?
No, what am I finding a picture? Oh, the bullseye?
Yeah,
Yeah.
so they can actually know what that looks like. And then what else you guys mentioned? CT scan, blood cultures. Yeah, those are all good. I'll write them down in a second. Yeah, I don't think I have any pictures of it, but yeah, like definitely blood cultures. You can
How do
get
I how do I link it? Oh, wait. I think I got
oh,
it.
CT scan, and usually prior to the lumbar puncture. There's also like a chest X-ray to kind of rule anything out. Oh, that's a really good one.
It looks crunchy.
Yeah. So let's kind of get that over here. Is it gonna paste? Nope. Let me see if this works now. Okay, perfect. So that's what that looks like. You get the halo bullseye looking thing. What else did you guys mention about? You guys are very active today. So that's staying still. So you don't want them to be like moving around too much and stuff. Um, yeah, like avoid kind of like drastic movement, keep head straight, don't flex like at the hips, don't bend at the hips rather. Yeah, that's a important thing to always keep in mind as you always want to do cultures before you start antibiotics. So that is definitely something you need to be aware of and you um always culture before antibiotics. Okay. So kind of back to the lumbar puncture. What position are you gonna wanna like what do you want to do with positioning in terms of lumbar puncture? And then maybe what positioning do you want with a patient with increased ICP? Like what position do you think is good? I guess we'll go over this one first. What's the good positioning for someone with increased ICP? Semi-Fowlers, exactly. So that's gonna be good. Semi-Fowlers, and if you guys get it, it's like specifically 30 to 45 degrees. So semi-Fowlers is how you want it. What about after a lumbar puncture? How do you want to position? Do you want them to go straight back into semi-Fowlers? A lateral recumbent. I believe that means like on their side. Yeah, so there's gonna, yeah, during and then after.
Because the positions differ.
Sure. This one is just on their side, right? For the during.
E,
Yeah. So I guess we'll do the technical term.
the
What about
government
after?
name.
The government name. What about after? So you kind of mentioned that we want them in semi-Fowlers to kind of decrease the intracranial pressure, but we also want to prevent leakage of cerebral spinal fluid. So how do you kind of hit two birds with one stone kind of thing? Or how do you adjust that or how do you deal with that? Do you want them to stay lateral recumbent, like flat side lying, or do you want them to go semi-Fowlers or what are you going to do? Okay. I'll wait until maybe if you guys get some answers in. Dorsal recumbent before after. I don't even know what dorsal recumbent is. Let's see. What
I
is
think
that?
it's referring to having yeah, the knees kind of tucked in a little bit more.
I
So
see.
like the lateral one is gonna be with the knees closer to the chest
Okay.
so that they could get in between the spine bones.
Okay. So we got a few more answers now. Um, let's see. For those saying flat, do you want them flat all the time, or do you want to do something after? Also, so you are gonna want to keep them flat initially. Well, I guess I said that word already, but whatever. Let's just kind of get through it. You're gonna initially want them flat, and then gradually adjust back to semi-fowlers. Because remember, you do want that head position to be at this amount. Semi-fowlers for better management of ICP, but after a lumbar puncture, they want to be flat because they also don't want to leak cerebral spinal fluid. So you kind of just have to get them flat and then gradually work your way back up to what you need to have them at. So, let's see. That should be good enough for that. So complications, this one's a little vague, so I'll just kind of be like increased ICP, um, seizures, because anything going on, pressure in your brain, you can have seizures. You can include maybe shock, a lot of pressure there can cause some, I'm sure things can start popping from all that intracranial pressure. So just things like that. What other management can you guys think about? So other than positioning, what else do you kind of want to do with someone with meningitis, an infection, increased ICP? So let's see, antibiotics. Yeah, you want to do some antibiotics for sure, some low light. So yeah, you can kind of um, cluster that into like decreased stimulation. So um, stimulation. So we talked about photosensitivity. Is there anything else that they'll be sensitive to? Sound, yeah. Reduce sound. Yeah, so that's called photosensitivity, and then the other one's called phonosensitivity or phonophobia, yeah. Whichever one. Just know phono means sound. Yeah, you're gonna want to have IB fluids and stuff. Oops. For the most part, people with infections want to have IB fluids running. So we kind of mentioned that they have the potential to have this increased ICP and maybe take a look at some of these signs and symptoms and tell me what's something you want to assess. Want to be like assessing. Yeah, so remember here, your altered level of consciousness is going to be one of your first signs of ICP, increased ICP. So it makes sense that we're going to be assessing for the presence of neurodeficiencies before you start assessing for all this stuff. Obviously, you want to watch out for this, but if you are going to have this, this is going to be the first sign you'll see. So that's going to be one of like the main things you're going to be really looking out for. Perla, yeah, like pupils and stuff like that. That's a part of your neuro assessment. It's like checking the pupils and whatnot. So yeah, you're going to be doing neuro assessments. Do you guys get told how often? If not, I think every, yeah, every hour, I think it makes sense for the patient. Uh, let me see if there's anything else. So complications that could happen, like a septic shock, we mentioned that. It could even be like a hypovolemic shock. Remember, DIC can come from shock in general. Let's see. Ba, 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 ba. Okay. So what else can we do to manage inflammation? What else can we do to manage really high pressure in the head or just really high pressure? Yeah, you guys were specifically told mannitol and furosemide. Mannitol, um, diuretics. Mannitol is one of your main ones there. Furosemide was also mentioned in your guys' PowerPoint. Mannitol is probably your number one. This is osmotic diuretic, so it's gonna cause things to shift back into the intravascular so you can get it out. This one's going to be very good for ICP, reduce the ICP there. Steroids for inflammation, yeah, so you're going to want some IV steroids for some inflammation. Good. Something else we mentioned is that patients at risk for, or rather, I'll actually let you guys figure it out. So, what's good about? Why do you want to decrease stimulation? What can you end up causing if patients overstimulated, too much going on, too much light, too much sound? Your brain has pressure on it. Yeah, seizures. So you can think about seizure precautions. So what does that kind of include? Yeah, this is your hyperosmolar. Yeah, anticonvulsants. Good. What do those include? Like what class names? Safety is always important, yeah. What do you want to have? Someone's on seizure precautions. What do you check in the room? Yeah, you want suction at bedside. What else do you want at bedside? Yeah, you want O2, have some O2 ready to go, like the cannula ready to go. You can even, yeah, you could even have like if it gets really bad, I guess with hypoxia. Remember your seizures can cause hypoxia. They need to be intubated for some reason. Yeah, you want to pray you don't have to use it, but you want to have it just in case. At bedside just in case. We mentioned anticonvulsants, we mentioned IVs. So how many IVs do you want? What gauge do you want them to be? Someone goes into a seizure and they don't stop seizing. That's called epilepticus. Yeah, you want two large bore. You want at least two, like multiple large bore IVs. So that's either 18 or 20 or even smaller if you can, I guess. So like and smaller by smaller I mean like the number is smaller, not the actual like remember as you go down in gauges that means they're bigger. So you want large bores, 18, 20, 16. So you can infuse a large amount of solution in, and you always want to have multiple, like a two, because let's say this person's getting fluids, right? And now they're ceasing and or they're getting like antibiotics IV piggyback. They're ceasing and like you need another you need to have an IV ready for you to start infusing the um anticonvulsants like an IV benzodiazepine, an IV like barbiturate, uh and stuff. Or also just in case like one of them just your IV doesn't work. So what happens? Yeah, like Caitlin says, if you're infiltrating, if you're running heavy amount of fluids, you're running all this stuff. What if it infiltrates and now this person seizing? Imagine how much of a problem this can be. Um, even if it's not like imagine like for not seizure patient, they only have one IV, it's infiltrated, and now you have to go through the effort of putting an IV on like a normal person. Like that's already the effort of having to put a new IV while this person is like potentially dying. But now imagine this person's having a seizure that's not stopping. Imagine trying to place an IV on that person. So definitely you want to make sure you have multiple IVs on this person and some of your anticonvulsants involve benzodiazepines. So that's your Zolams. I always like if I see them, I recognize them, but the endings always elude me. Yeah, Lam and Pams. barbiturates, phenytoin stuff. Probably more of the first two than anything, but yeah, you can get anticonvulsants going for that person if they have seizures. Um, so not only do they have the risk of having seizures, what are some of the issues that occur on a neuro patient from the seizures, if you guys can think about? So what do the seizures do? How do they affect you, I guess, is what I'm trying to say. Yeah. Not so much brain damage, maybe over periods of time. And if they do have brain damage, why would they have brain damage? What's actually causing brain damage in that situation? Kind of aligns with your ABCs. Yeah, exactly. You have ischemia to the especially with your tonic-clonic seizures, you're not really able to breathe, so that becomes one of the issues is why you want to have O2 is because hypoxia. And remember, your brain doesn't have any storage of oxygen. If it's not oxygenated, your brain has certain time limit before it starts having brain damage. Tissue starts dying, or time is tissue. So you don't want them to be hypoxic. So you want to prevent seizures because they can go hypoxic. That can cause brain damage. Also, remember we were saying is that we want to decrease stimulation. So, and one of your patient educations was to avoid drastic movement and all this stuff. So all this movement, all this brain activity is going to cause even more increased intracranial pressure, which is kind of what we're worried about. Remember that you can have really poor prognosis from this increased intracranial pressure happening. Remember, one of your irregular breathing when your ICP is really bad is your Cheney-Stokes respiration, which if you remember, they defined it to us as kind of like the breathing that might be a signifier for impending death. So that's like a way for you maybe to think about it. You really don't want to have increased intracranial pressure, or you want to make sure to prevent as much as you can. Yeah, side rail padding as well. You want to make sure that the side rails are padded. These are probably your main ones here for your seizure precautions. Okay, we talked about neuro assessments. We talked about steroids. The specific one they mentioned is Decadron, so that's dexamethasone. But remember, all your ONs, ONE, those are your steroids. Okie dokie. And what are some things you want to really look into for um, someone that's on steroids? Yeah, so does it cause hypo or hyperglycemia? Causes hyperglycemia, exactly. And like I always say, like the steroids, usually like the ones they give are called glucocorticosteroids, so the word glucose already in the name. So that's easy way to remember that. Awesome. So that's pretty good. Let me see if there's anything else. We can move on to patient education. We talked about CSF leakage. Why does it cause hyperglycemia again? Yeah, so kind of think about your steroids are going to be medications that how do I break this down? So including your class of steroids includes cortisol. Cortisol is a type of steroid as well. Once you have like a buildup of steroids, remember cortisol is your stress hormone. You end up having kind of like a fight or flight response. So um, one of the things your body does when it's in a fight or flight, it wants to be alert, it wants to be ready, so it shoots up it releases it releases a bunch of sugar because your body uses sugar for energy. So it allows your body to have that fight or flight. So your steroids kind of stimulate that. The reason they decrease inflammation is kind of like if you're in a fight or flight situation, it's kind of like the idea, am I worried about the inflammation? Am I worried about infection, or am I worried about eating? Am I worried about digestion or peeing, or am I worried about the tiger in front of me that's about to kill me? So that's kind of the rationale behind the fight or flight and why it causes some of these things. So hyperglycemia um, cause from that, and you'll learn more about it in third semester as well. You'll go through Cushing's syndrome, Cushing's disease later on. For now, this is probably just your key thing is you want to think about is your hyperglycemia, and maybe also it can make you a little immunocompromised. So if you guys remember with your COPD and stuff, they inhale steroids. So you need to have them rinse their mouth because it can cause them to have like oral thrush because um, that area is going to be more susceptible to infections and stuff. You're getting rid of your good flora and allowing like opportunistic infection happening there. So alongside your patient education on CSF leakage, we told them avoid drastic movement, keep your head straight, don't bend at the hips. This might be something better for like before, but there are vaccinations for meningitis, bacterial meningitis. You can get vaccinated for it, so that's something to keep in mind. Yeah, droplet precautions as well. Kind of goes all the way back here, right here with the bacterial, you have droplet precautions. Yeah, just at the very top. I know it's I guess something to do maybe like teach visitors, family about droplet precautions. Good. Kaylin wants to ask you guys who's at risk for meningitis. Yeah. Jails, college dorms. Yeah, you can kind of crowd that together with, yeah, nursing homes, kind of like crowded areas, packed, crowded. Yeah, exactly. You guys got it on that. I guess something else. Not sure how much they mention it on you guys. I don't think they do, but kind of goes along the lines with wanting to decrease your intracranial pressure. We do that by decreasing stimulation, decreasing the risk of seizures. Something else that, and with their position changes, making sure that they're not moving around too much, no drastic movement and stuff. Something they can also do is antiemetics. Because remember, your ICP can give you nausea, vomiting. Antiemetics um, can help as well because vomiting, you can imagine if you guys have, when you guys vomit, you you're kind of straining. So things that prevent straining. So antiemetics, stool softeners to prevent straining can be something that can be done because straining increases your intracranial pressure. Maybe even managing pain if they're in pain. Pain can also cause more intracranial pressure. Remember, when you're in pain, you're anxious, you're straining, your vital signs go up. So remember, patient in pain is gonna have like can have a tachycardia, a little bit hypertensive. So just things to keep in mind, just kind of think about as well. Let me see if I have anything else. Anything else you guys can think about in regards to this? Or any questions as well? All right. The only other, yeah, you guys are really good. You guys are doing it. Gonna kill the test. But yeah, only other thing that might be like, I guess maybe not as much important. Yeah, don't kill your patient. Yeah. Something else that maybe it's just a fun. I don't think it's super important to know, but maybe like a fun fact is that with bacterial meningitis, um, your antibiotics will actually make it worse initially because the bacteria die and then they release toxins that cause even more inflammation. So, or I think even like the main pathophysiology is actually the bacteria dying that causes the inflammation. So the antibiotics um, actually worsens your condition initially, which is why the bacterial meningitis can be such so difficult and so life-threatening because treating it is makes it worse before it gets better because of the lysing of the bacteria. So that's just like a Snapple top fact. Alrighty. Let me see if I have anything else for you guys. I think I might have. I do. Okay. So here is something I can put at the top, I think. A little table. I said I would give this to you guys. Just another way to kind of have it all in one little area for meningitis. All right, cool. And then yeah, obviously you'll have like flu-like symptoms. That's something we didn't really go over, but that's kind of makes sense and stuff. And obviously your antibiotics, if bacterial, antivirals, if it's viral, makes sense. Usually just look for the ones that end in like clovir or just vir. They'll usually end in that. Probably with a I instead of like acyclovir and stuff. Yeah, beer for virus. Exactly. Alrighty. So we're ready to move on to encephalitis. Encephalitis. So this one, kind of like the other one, it's involving the meninges still, but encephalitis also includes some inflammation of the brain tissue. What are some signs and symptoms you guys can think about? Let me see if I can get you guys anything to go about. There's some like etiology stuff, like commonly comes from herpes simplex or West Nile virus, but I don't think it's as important to know. What do you guys got? You guys got ultra level of consciousness, yeah. Oop, meh. Ultra level of consciousness. Yeah, you can still have a stiff neck with this. Yeah, you can have some flu-like symptoms like fever and stuff. It's actually got a lot of very similar symptoms to the meningitis. So along the ultra level of consciousness, you have increased ICP as well. So kind of that goes in there. You have nausea, vomiting. You can have photophobia, so it kind of goes along with that. Photophobia, essentially photosensitivity, same thing. But it just means you are really sensitive to light. It's spelled sensitivity. Sensitivity. There we go. Yeah. So yeah, is it less painful than meningitis? I don't know. I've never had either. I'll try to have it and get you back to you on that maybe. I'm just kidding. I don't know, honestly. Oh, you've had it? Oh, wow. Well, yeah. Yeah, based off the symptoms, and just based on the definition, you have inflammation of meninges and inflammation of the brain tissue. With your meningitis, the inflammation on the meninges can cause pressure on the brain, but this will have direct pressure on the brain. Damn. Yeah, it's typically diagnosed from your clinical history and manifestations. So a lot of them though are very similar, but there are some tests for it. They'll do like a CT scan to look at the cerebral spinal fluid, PCR, which is like a virus, your polymerase chain reaction. You can see assess like DNA, RNA of pathogen stuff. Kaylin wants to ask, what are some specific signs and symptoms for encephalitis? So we'll do kind of like compared to meningitis. So we kind of said already that it's going to affect neuro more heavily than meningitis. You're gonna have worse off conditions and stuff. What else? Yeah, motor dysfunction. So that kind of goes there. Motor dysfunction. So you can have dysphagia, difficulty swallowing, pain and stuff. Okay, let's see. So you guys mentioned seizures, yeah. So a higher risk of seizures. Behavioral changes. Yeah, weakness, speech problems. I think you guys mentioned that. Behavioral changes, seizures. Yeah, weakness and speech problems. It it makes sense because when we are comparing it to meningitis, is it more in relation to viral? Not necessarily. I know this is caused by like a viral thing, but just kind of like as an initial assessment maybe before you can actually rule it out because you do your diagnosis to actually test it out, but just kind of someone coming in, you don't know anything about them. Um, some of the differences because they're pretty similar in terms of signs and symptoms because you can still have stiff neck, but in a meningitis, your nuchal rigidity um, is more pronounced in your meningitis. Anything else you want to add on, Kaylin, to some of this? I know you said you did the questions recently. So.
Oh, I put that in the chat to you. That pretty much hit on everything. So most of your stuff's going to be the same. You still have your ICP, your photophobia, nausea, vomiting, altered level of consciousness, increased ICP. But just because it is directly acting on the brain,
Hmm.
you'll end up with more neurospecific symptoms. So that's where the weakness or speech problems come in. I
Yeah,
like to think of it kind of, and I forgot somebody said paralysis.
yeah.
Where'd it go? I know it's here somewhere. Paralysis.
There's a
Um, I think it was just described as like motor dysfunction, but
Yeah.
paralysis, I could definitely see that. So you get more neurological specific symptoms.
Hmm. And I can't imagine they'll actually make you do a differential diagnosis. You're not a doctor, but just things to keep in mind because I know they can get confusing because they're so similar. But this is just would probably just be for your sake. Just know encephalitis, encephalo means head. So inflammation of the head versus just the meninges. This affects not just that, but also the brain tissue directly. So you can kind of logic out that it's going to be more uh more heavy on you because your brain is directly involved. All right, so we got some of the diagnosis. What about your management? So we said it's a viral, so what do we want to do about that? Acyclovir, yeah, antivirals, of course. Perfect. So, and then here you'll see a lot of similarities. You'll see um, anticonvulsants because remember you can still have seizures. Yeah, have an actual higher risk of seizures. So anticonvulsants, seizure precautions go along with that. Yeah, you'll still have IV steroids. They again, Decadron, the one they mention a lot. Antibacterials, I don't think much because I think this one's purely viral. So antibiotics aren't really going to help.
I just realized I had my mic unmuted this whole time. Um, for what we have in encephalitis, it could be caused from bacteria, fungi, or parasites as well. But
Okay.
mainly it is viral.
Okay. That's something I didn't know. All right.
And
Sure.
Anne is asking for the hallmark for meningitis.
Got to be your nuclear rigidity, I imagine. And um, yeah, because there is a difference between because otherwise maybe you can think about the cerebral spinal fluid changes and stuff, but definitely that one. Here, again, you can still have it, but it's not going to be as bad. And some of the other symptoms will be more telling, like they will be far more neurologically impacted and stuff. Some of the other ones they mentioned here, um, propofol. They mentioned propofol, which is diproban, which is a sedative. So they can put them on sedation with intubation and just kind of put them in a coma to heal, like put them in a little coma to heal. And something else they mentioned was you can get Tylenol um, for reduction of fever. And typically this is given PR meaning per rectal or per rectum, so in the butt. These patients are not really gonna want to take PO meds. Remember, they're more neurologically impacted. Dysphagia, you don't have them want to have them choke on anything. So put it in the butt. All right. Any questions on this? See if I can get a good picture of. I like this picture. Inflammation of the brain. Any questions on anything so far? I think we've been at it for like an hour. The next few are probably a little bit faster. Some of them are just like little tiny little things. Okay. So we have Guillain-Barré syndrome. You might have, I think you might remember having to learn how to pronounce this word, or maybe like slightly on how to or what it is when you guys were doing injections. Some of you guys got like a flu shot in 212 is for your CPE. So one of the things to ask was about Guillain-Barré syndrome as well as like egg allergy and stuff. But the definition I just kind of wrote out for you guys. It's just the demyelinating disease of the peripheral nervous system. It's kind of the big there, caused by an immune response. So demyelinating. You guys can see kind of what that looks like. You have your neurons have like this little myelin sheath that allows for conduction. So this is what it normally looks like here. And when it's deteriorating, it'll start looking like this. It's like this little protective barrier for it. Allows for better conduction over time, or not over time, but from the disease process, you'll start having demyelination. It maybe even gets to the point where it starts like actually impacting the axons of the nerve cells and stuff. Okay, I think the main important thing to think about here, one of the most important things to think about, is this temporary or is this permanent? Do you guys agree with Celeste? Awesome. So yeah, this is going to be a temporary. But um, if someone, let's say there's a patient, your patient has GBS, that's Guillain-Barré syndrome, and the visitor comes in, like the patient's wife or something comes in and asks about the condition, you'll tell her it's temporary, but then they ask you when are they going to have a recovery? How would you answer that? Can you guys give a definitive answer on exactly October 31st at 12:51 p.m.? Yeah, it can take a while. It can temporary, and I would kind of define as like a slow, partial, or full recovery. So it will take months, years to recover. You can't really give a specific time frame. So that's something to keep in mind. Did you have a question like that in your session, Kaylin?
I don't think I talked about that.
Okay.
I
Might have,
mainly just talked about like the main complication.
oh yeah. Could just maybe like a potential Kaplan question. I don't remember. Something like that. So etiology, I'll just kind of write this one down. There's no direct cause, it's believed. It's idiopathic, meaning it's not really known exactly how um, it comes to be, but it's commonly caused from a previous respiratory or GI infection. Okay, so what are your manifestations? There's one really, really big thing. Okay. Yeah, you will have paralysis. Can you explain that a bit more? Paralysis. Okay. Kayla, can you explain how it causes that? What kind of
What?
paralysis is it?
What?
What?
I didn't hear.
Hear what?
Oh, I thought you asked me. I was like, what?
Oh no, I said Kayla, not Kaylin.
It was similar
It is similar.
in the feet to store.
Yeah, so yeah, it's like called like an ascending paralysis. So your paralysis will start working its way up, starting with the lower extremities, and working its way up. Someone mentioned, yeah, the paresthesia. So the first sign is weakness or tingling. The tingling is called the paresthesia in legs or feet or legs. Awesome. And yeah, so it's working its way up. So eventually it's going to start affecting the respiratory muscles. So that is your big thing that you want to think about is that it eventually affects the respiratory muscle. And because of that, it can affect your breathing. It can cause respiratory failure, probably like a ventilatory failure. You're not able to breathe. So person might need to be like intubated or something. So that's your really big thing that you really have to know about this. Your biggest thing. There are some other manifestations, but this is your biggest one. Let me see what else I can do. So ataxia, I believe that that's true. So you have like your ataxia, maybe like some flu-like symptoms prior to it starting. What else can you guys think about? Yeah, so difficulty speaking, swallowing, facial muscle weakness, aspiration. So kind of all makes sense with the ascending paralysis. So you got to really worry about eventually there can be dysphagia, um, risk of aspiration. Yeah, over time, muscle atrophy. So what would be something that might indicate early respiratory impairment? Yeah. So what's something you might hear or might see or might hear um that could be a sign of like an early sign that it's starting to affect the respiratory muscles. So before you get to this stage, instead of going from like 10 to 100, what's like the in between, some things that you might see for signs of respiratory like impairment. Okay. Yeah. So mentioned let's see, early signs of respiratory impairment, like said labored breathing with accessory muscle. Cap refill, SpO2. I could see those potentially. Probably mainly the SpO2. Your cap refill is more like a perfusion directly. Um, Something else to think about is maybe Kaylin mentioned like a weak cough. Kind of like the similar idea to like um like when your airway is breathing or when your airway is breathing when your airway is closing. Not to say that this is closing your airway, but um kind of like the person goes from having a strong cough to being like like having a harder time. So here, Kaylin mentioned trouble breathing, weakness or paralysis can spread to the muscles that control your breathing. Um, yeah, they can have help from a machine, get intubated and stuff. There's a few other things like obviously if you're having paralysis moving up, eventually it's not just going to affect your lungs, whatever is below it. So like bladder, like lack of bladder control, bladder bowel control. Yeah. And then yeah, once it gets to the respiratory muscle, you'll have all this stuff happening, and then over time, respiratory failure, you literally will not be able to breathe. You can't bring the strength to breathe. You'll be on like intubation and stuff. Okay. So then just wanted to go over management. There's some stuff I'm skipping. I'm skipping like the phases. I don't think it's as important. Um Diagnostics. Um I guess I could include those. It's kind of like typically from physical manifestations. So maybe like deep tendon reflexes. There's like a nerve conduction studies or something. Yeah, apparently you can do a lumbar puncture to you can have increased protein without an increase in cell count, whatever that means. But I think the main important thing with this is the airway and your management. So we already talked a lot about that. So obviously you're gonna assess the airway. You're gonna assess respirations. It's gonna be important. Patient might have to go on a ventilator. They're gonna be on the bed for a while. So what are some things you want to think about? They're not really able to move. They're gonna have trouble eating because they're have dysphagia. So what are some things you guys think about when someone's immobile and unable to eat? Yeah, they're at risk of DBT. So you want DBT prophylaxis, um, pressure injury. So you're gonna move them, turn them regular, assess their skin. What about nutrition wise? You're gonna want to do like aspiration precautions, but if they're able to eat, you can try to see if there's a diet that works for them, like a soft diet or bland diet or something that works. So there's an aspiration risk, but if they're able to eat, they can eat. Aspiration risk. I think it's if unable to eat, yeah, parenteral or parental nutrition. So dehydration. It's probably be like on I like IV fluids for that.
I was gonna ask about the parenteral nutrition. If I remember that, that's TPN, right?
That's what, yeah, based on what they have on their PowerPoint, that's what it says. Because I was thinking about that. You'd probably want to do like enteral feeding through like NG tube or a PEG tube or something first. If you're,
Interesting. I
yeah,
see
if
it.
yeah, because in general though, if you're able to, you wanna feed their stomach. Although maybe with the paralysis, maybe their stomach isn't really churning either. So maybe that's something to think about. Maybe they're not just unable to eat from dysphagia, maybe they're also unable to digest properly because the stomach muscles are paralyzed. Maybe that's the reason. Because otherwise, in general, if you're able to, you want to do enteral feeding, like feed like directly to the stomach through either an NG tube or PEG tube if they're unable to swallow, because TPN is obviously more um, it's gonna be more expensive, but it's also gonna increase the risk of like infections. You'll learn more about this later, but if you're not using the GI, you run a higher risk of infection. But for this, they were talking about parental nutrition. So like a TPN, maybe a PPN or something like a peripheral parental nutrition. All right. Any questions so far on anything? Try to get through the next few more quickly. Oh, I guess we're still not done actually. That was just non-pharmacologic. My bad. Yeah, the eye. So I have trigem. I have all this stuff first, and then glaucoma and eye stuff is towards the bottom. It's just there's a lot of stuff. It's a lot of stuff here. Yeah, there's a plasmapheresis for pharmacologic. It's possible to do. I'll just kind of talk about it. I think maybe try to speed things up a little. Corticosteroids.
Diego, why do they do the plasmapheresis?
Let's see here.
I believe
Plasma.
that it wasn't like fully specified for you guys.
No.
Let me go through the causes again, because yeah, I don't think you guys went over it at all.
Yeah, they just kind
Remember
of
I
told
looked it
you.
up.
Yeah, but typically, what that is filter, remove plasma from the blood. Um, I think maybe because usually it's done for like autoimmunes. I think here I didn't mention it here, but I guess the idiopathic, but I think it's can be considered possibly autoimmune. I think it's kind of like what I was kind of mentioning. And then there's IVIG and stuff, which is typically also done for like autoimmune conditions. So yeah. Think it's not like definitive that it is. Kind of like was it I think your ulcerative colitis, or it was one of your UC or your Crohn's can be thought is also like not definitively autoimmune, but it's considered practically autoimmune. And I think this one's the same, that it's thought to be caused by yeah, well it says here immune response here. But yeah, it's considered possibly like autoimmune. It's thought to be autoimmune. So then that would make sense with both of the plasmapheresis and the IVIG, which are typically for autoimmune conditions. There's a lot of specifics, but I think you guys were kind of just dropped the information and they called it a day. So I wouldn't focus too hard on it. Just know that they're used and not so much why, or don't, yeah, there's not, just also remember there's only so much detail they can add on the final. Just try to keep big picture kind of energy, big picture stuff. But yeah, that's typically what it's there. Your IVIG is kind of like decoys for your autoimmune diseases to kind of focus on and leave the rest of you alone, kind of. It's like a little decoy. And then the plasmapheresis is you're basically filtering, removing plasma from the blood to try to get rid of antibodies in the plasma. So it's kind of for autoimmune stuff, and this is thought to be autoimmune, so that's kind of the purpose. So let's see. So I'll write that here. Plasmapheresis, remove and filter plasma, remove harmful antibodies. All right. And I think they just said NSAIDs for pain, but that's it for that. Galen,
Ha!
do you mind if you take over? Could you take over for a little bit?
You have to go to the restroom, don't you?
Yeah, I'm kind of hungry.
Bruh, okay. Let's see exactly where you left off at.
Yeah.
Let me open it.
I'll leave it like this. I'll be back soon because you
Uh,
can edit it because I know you have access to it.
I do, but if I need to scroll the screen down, that's an issue.
Yeah,
I'm gonna overtake your screen,
that's
sorry.
fine. All right, I'll be back.
Oh, what? Wait, no, come back. Oh, it doesn't let me share it. Dang it. Okay. So we are on, he finished up GBS, right? Just want to make sure. I think that was pretty much everything. Will be, yes, ma'am. Oh, don't call me ma'am. I feel so old. So the next one we have trigeminal neuralgia. It's compression of the cranial nerve, the fifth one, which is also known as your trigeminal. It's gonna have one big specific manifestation with it. Pain, super pain, face pain. That is gonna be your biggest one. From the smallest things too. They can have like it could just be touched. If they try to move it, if they chew on that side that's affected, um, let's touch chewing on same side. There we go. That can really set it off as well. There's not too much that goes into the trigeminal neuralgia that you guys have to know. Um, I would probably just know the description of the pain. So how would someone with trigeminal neuralgia describe their pain? Oh, facial pain, yeah. What is it? Dull? Is 12 out of 10? Yeah, super severe. Is it dull? Is it stabbing? Is it sharp, stabby, dabby? Yeah. So sharp, stab. Oh God, stabby and severe is your big ones right there. I'm switching back and forth to make sure that I get everything that he would have wanted to put. I don't think he put it here. There's not really a clear way to diagnose it. It's pretty much just ruling out anything else it could be neurologically. So you're going to do your CT and MRI to rule out if it's anything else going on inside the head that could be causing this. And then if not, it's just a basic history. Um, because like we said, it's compression. So things like a tumor on the nerve or MS or just compression, however it occurs, will end up causing that. So they'll say like, oh, I had this thing happen and then this pain happened. So it's mainly going off of history, but you still want to do a CT and MRI to rule it out. In terms of your management, how are you going to manage it? Let me split this into farm and non-farm. He's gonna hate the way I wrote this, but you know what? We're running with it. And surgical. Anticonvulsants, yes. Oh God. I love the nail one. That is so funny. So anticonvulsants. Yeah, that's a good first line. Yeah, don't have any caffeine. No caffeine or stimulants. There we go. So your anticonvulsants is a big first one because, if you're giving like carbamazepine, which is your Tegretol, um, if they end up having like an improvement of their symptoms, it confirms the diagnosis of trigeminal neuralgia. So I'll put that there. Doo-doo-doo. Nerve pain meds. Yeah, so that's your gabapentin Neurontin. Yeah, yeah. Oh God, gabapentin Neurontin. Oh God, I don't know how to spell. Yeah, so that's gonna be your nerve pain one. It's technically also used as a anti-seizure, but I think in this context it's used mainly for nerve pain. What else? What other meds could we have? We have severe pain and spasming of the muscle in the face. So we've talked about controlling your nerves firing. What else can we do? Did I not finish writing this out? Nerve pain. There we go. Okay, cool bean. Those jumping back and forth between pages. The last one is kind of a random one, so I'll just talk about that. That's your baclofen. It's a muscle relaxant. So because we have facial spasming and pain, if you give baclofen, a lot of times it helps with your muscle spasms. So it helps calm it down a little bit, helps with the pain alongside of that. You could also just do like a local nerve blocker. So maybe like injection. Oh God, injection of, I think lidocaine was the one that they told you guys. Oh, they didn't even tell you guys one. But yeah, so some kind of local nerve blocker into the face to help with the to help numb it. Oh God, how do I spell numb? I don't know how he talks and types at the same time. I cannot. I'm so bad at it. Lord
I'm
help me.
I'm back.
Did you already eat?
No, but I'm back with some lumpia.
Ooh, Queen. Love that for you. Okay, well we got through farm for trigeminal neuralgia. I split it into three because you have farm, non-farm, and surgical interventions for it.
Yeah, I'll let you finish trigeminal.
He's got like half his face stuff. Oh, what's to finish? I'm just messing with you. Well, yeah, so that's going to be your main ones for your pharmacological. This is going to be the biggest one because if you give it and they improve, we know exactly what's going on. These are just kind of like adjuvant, like we can add it on to help with their pain and help with their comfort. Non-farm, I like the idea of no caffeine or stimulants because, I feel like anytime you have caffeine or stimulants into there, everything speeds up, nerves speed up, so on and so forth. So I don't want to make things worse. What other non-pharmacological interventions can we do? Ice packs I'd be a little careful about. So that's part of the patient teaching. I'll put this down here, education. Simply just because you guys were told avoid foods that are hot or cold. So like the both ends of the spectrum. I don't know about y'all. I have messed up teeth. I promise this is somewhat relevant. I got messed up teeth, so if I bite into something that's really cold, like we were talking about ice cream earlier and ice cream sandwiches, if it's too cold, I get a lot of pain in my tooth because it's hitting the nerve like right on. So same kind of idea. If I put something that's on the extremes of it, if it's too hot or too cold, I might trigger more pain. So that one I'm a little wary about. Maybe like a cool pack, but not an ice pack. I wouldn't say an ice pack. Uh, but yeah, so we have a lot of pain on our face, but like right around our mouth as well. So what can that affect over the course of time? Oh, last cohort party. There's a sign up sheet. Okay. But yeah, so if we
Ooh,
have
more
all that
food.
pain around our, yeah, nutrition. Nutrition. So that's gonna be a big one. So what do you expect is gonna happen with their nutrition status? DIY costumes encouraged. Fun. And pumpkin painting. Oh my god. Do I expect their nutrition to get better, to get worse? Fluid intake. Yeah, I don't know about you, but when I'm in pain with that, like when my tooth starts hurting, I don't even want to eat or brush anything on that side. Like I won't touch it. So same kind of thing, same kind of ideology with them. They don't want to eat. They might not want to drink fluids as well. So with that, our fluid balance is shown off. So is thrown off. So what are your interventions for that? Like what are you monitoring for fluid balance? You just general fluid status things. How do you assess for fluid status? That's not how you spell that. There we go. Any guesses? The general one too. It's nothing specific to the condition. It's just how you manage your fluid. Yeah, there you go. Your eyes and nose. And whenever you see your eyes and nose, you're also thinking daily weights as well. This one, we're on the different end of the spectrum, so we're going to be not having as much in. But with that, they might be losing weight as well. So possibly daily weights, but your INO is going to be really important here. Just because they might not be tolerating oral intake. If anything, we might have to, if they are severely dehydrated and they come into the hospital, we'll probably do IV fluid rehydration just because they're not willing to put anything in their mouth. I wouldn't be willing to either. Those are your main ones for non-pharmacological. So your fluid balance, they're not going to be able to put anything in their mouth. Oral care, they don't want to brush their teeth. They're going to have too much pain. So assess their teeth, their gums, inside of the mouth, look in there. Um, and just avoid foods that are too hot or too cold. Don't want either end of the spectrum because that's a huge shock to the nerves, essentially. Is there anything else? Okay. Wait. Don't eat foods too hot or too cold. There we go. Oh, it's right here. I'll just take this part out because it's right there. Okay. That's it for the non-farm. Now we're moving into surgical care. Lord, I would cry if I had to do these. Oh, oh my gosh. So what are you have two of them. What are your two examples for your surgical management?
All right, I have finished lunch and dessert, so I'm ready to.
And dessert?
Yeah,
You genuine menace.
yeah. I had the lumpia and the turon for dessert.
Oh, you guys actually got a final study guide?
We did too. What do you mean?
I don't know. I don't remember. Okay, that's fair then. Honestly, if it wasn't there, maybe just don't go through it. I'll just
Just know,
copy.
yeah. Just know it's surgical. Just know there's surgery
Know that
for
you
it.
can.
Know that you can.
Okay, my bad. I did not know that for you guys. So that completes it for your trigeminal neuralgia. Your main things you're gonna have to know: face pain, face spasm, sharp, stabby, severe, um, painful to touch, heat, cold. That doesn't look familiar at all. They might not want to chew on the same side as it because we have a whole bunch of pain on that side, kind of like when you get like an abscess on your tooth or something. They don't want anything to do with that side of the mouth. So anticonvulsants, if they have a positive response, confirms the diagnosis. And then in addition to help comfort, you can give stuff for nerve pain, muscle relaxants, and injections to help numb as well. Just watch their eyes and nose mainly. Assess their oral mucosa, no stimulants of any kind. And I think those are the main things you really have to know for trigeminal neuralgia. Very short section right there.
Yeah. All right. Good job.
Yay. I don't know how you talk and type at the same time. I cannot do that. I really struggled.
Years of practice. I don't know. Here's a picture. I like the osmosis pictures. I think they're
I do
always helpful.
too. They're really good.
Yeah, although I will say just kind of knowing trigeminal neuralgia and the fact that it exists is probably good enough. Getting like a general idea. Baclofen, you'll see baclofen a few times. Just kind of get the fact that it's a muscle relaxant in your brain. Um, remember all the zepines, all the anticonvulsant endings. Neurontin, just get it in your brain cells that it can be used for nerve pain.
Yeah.
Yeah, I think that's pretty much that. Let's move
Yeah, I
on
was like, that pretty
to
much covers what you really needed to know. So on to
yep,
Bell's palsy. Yay.
the Bell's palsy. All right, so I kind of wrote down a definition for you guys because again, I don't feel like it was as important that you guys had this like active into your like active recall part of your brain. So it's just the acute paralysis of your facial nerve. That's cranial nerve 7. Can affect trigeminal and auditory, but it's like extra info. Um, More extra info. It can typically be caused by. It's basically typically caused by a herpes virus. Um, what I think could be good is maybe thinking about the risk factors for Bell's palsy. What do you guys think? Was this in your study guide? Let me know what stuff isn't in your study guide, by the way. I don't want to waste time if it's not even going to be tested on it for you guys. Y- Although I will say, Bell's palsy came up in our Kaplan in 240, so I'm like, oh,
It's a good thing I did neuro questions that I like made some because that's the only way I knew it when we did our Kaplan.
yeah. Yeah, our 240 Kaplan was comprehensive from the entire nursing program. It's okay. We kind of ate that though, you know? We kind of ate.
Queen. Yeah, I think everyone got points.
Yeah, I think so. All right, looks like maybe this wasn't emphasized as much, so I kind of just go over it. So some risk factors for Bell's palsy: diabetes, hypertension, obesity, the usual suspects. No, generally, yeah, that's what I figured. Basically, the usual suspects. I have a little picture. I like the picture. It helps me remember it. So here is this guy. Um, Bell's palsy here. This picture kind of shows it. It almost looks like someone's having a stroke. It's kind of what it looks like. It's basically a stroke-like facial appearance without obviously having a stroke. It's just because your facial nerve um, is being impacted. It's acute paralysis of that nerve, so it causes your face to not be able to do all the movements that you're able to, because that's your cranial nerve that's specifically there for movement of the face. So someone said it was mentioned Bell's palsy. In your Kaplan, I think in your Kaplan they might have asked you like the specific like what specific cranial nerve it was. I don't believe you have anything like that in your actual 220. But you guys got blindsided by that in your Kaplan, I guess. Yeah. Did you guys guess 7? Oh, let's go. Oh, it's okay.
I was like, five's a good number. I like 5, so I clicked 5.
Yeah. I don't remember what I put. But yeah. So let's just talk about it then. If it's just kind of no generally. So it's kind of like a sudden onset, and it's usually unilateral, as you can see from the picture. So I think this is where the picture is gonna really come in handy. Just kind of think of this dude right here, and just kind of imagine his face when you think about it. So it's like a sudden onset, unilateral, as you can see from the picture. You might have some pain behind the ear or on the face. So imagine you could have damage, pain from pinching a nerve. Imagine you're pinching a nerve or something, and it causes you pain in your face. That you can kind of rationalize it that way. Kind of here, it can affect some of your other facial nerves. So, let's see, it affects your auditory. So maybe you have a little intolerance to loud noise. Uh, Something to keep in mind is increased risk of aspiration. If you're having difficulties moving your face, think of like your like kind of like some of the ways you would treat like or kind of deal with a stroke patient. They will have risk of aspiration because they're having some issues kind of, yeah, drilling, having some issues getting it up in terms of their face. Um, so like a drooping eyelid, inability to wrinkle your brow, a smile won't be all the way there. Probably like the main things to really think about. Just know there's pain, know there's aspiration risk. Let's see here. Um, I think a lot of it for your management or your diagnostics involve kind of ruling things out. So you want to rule out neurological deficits. So a lot of it is typically diagnosed from physical, and you're doing a bunch of tests to rule things out. Rule out stroke. You want to rule out um, maybe like a hypoglycemia. Hypoglycemia, you can have like these neurological symptoms, although they might not be like neurologically declined, but maybe just from their face, maybe like a hyponatremia or something. But the main thing they really tell you to kind of rule out is for the stroke. You want to rule out to make sure it's not a stroke or anything. Gonna be your main thing. Your first line is corticosteroids. Corticosteroids. Remember, this is caused by um, a virus, the herpes. Just kind of think about herpes. This guy looks like he has herpes, so just kind of think about it like that. He has like that smirk going on. Just kind of think about it. So just kind of remember it like that. So like your antivirals, IV corticosteroids. This is your first line. Probably that's what I would focus on. Just focus on aspiration, the pain, uh, antiviral, IV corticosteroid. You're trying to rule things out. And a lot of your education kind of stems from protecting your eyes. 'Cause remember, this guy's having issues closing his eyes. He can't wink at you. Um he can't like I say wrinkle his brow and whatnot. So a lot of that's kind of like protecting the eye, maybe glasses or something, artificial tears, like an eye shield. Diet would involve kind of eating on the unaffected side, similar to like a stroke patient, maybe like a soft diet. And obviously there are aspiration risks. So that's probably again that's your main thing. Maybe some comfort, maybe like a warm compress. It's probably the main thing you really want to think about for that. Just keep thinking of this guy's face. Keep thinking of this picture, and hopefully that's all you need. I can't imagine this being too in depth for that. Probably similar with the trigeminal. He kind of creepy though. Kind of, yeah. He's got that Bell's palsy. Meniere's disease. This is due to it's like a ear related. So I'm kind of called the transient disease of the inner ear, affects hearing or balance. I have a picture that goes along with it here. Here you can see again, you see like the little snail, like a little snail or like the little Naruto symbol there in your ear, but you don't just kind of know that carry the snail. Um it's like a picture of kind of showing you what's happening, but you don't have to know it that deeply. Just kind of understand there's accumulation of fluid in the ear and just kind of try to marry the idea that things to do with the ear affect balance a lot of the time. So um, things to do with the ear is tinnitus, so you'll have that ringing in the ear. It's episodic, so you'll have it every once in a while. And then another key thing is dizziness. So dizziness or vertigo being like an extreme amount of dizziness, as if the room was spinning. And you'll have nausea, vomiting, loss of balance, aka ataxia, trouble walking. So here your big thing your big concept, like big picture kind of idea would be keeping them safe from falls. Okay. Anne says, can they go downstairs? I would I would make sure to be with them and help them walk personally, I think would make the most sense. Just imagine this guy's basically a fall risk. Yeah, they're gonna go down, but not the way I want. Yeah, just think of this person as a fall risk. So fall risk. So just like you kind of cluster all of Bell's palsy as aspiration and pain, maybe. Think of it like aspiration, risk, and pain. Those are main things. You can kind of cluster this as like a big fall risk issue, your big picture thing. Okay, and doesn't typically cause pain, so we're gonna move on from there. So I want to get to eyes because that is important. Management, the medication they specify is meclizine, aka antivert. Hopefully they give you guys the brand name for this one because anti-vertigo, like literally kind of spells it out for you that it's going to be for the vertigo, aka for the um, loss of balance, the nausea, vomiting, dizziness. So that's going to be obvious if you see the word antivert. Okay. You're gonna want to dim the lights and reduce sounds to minimize symptoms. See what else they do. I think they want to be better at. So yeah, don't they're gonna go somewhere, you gotta go with them. You're gonna make sure you are gonna go with them. I'm trying to just get all the big picture things out. Maybe antiemetics because they're dizzy and they're nauseous. This is caused by fluid buildup in the inner ear. So one of the medications that they have in your guys' PowerPoint is your hydrochlorothiazide. So the HCTC. Where are we at? I think that's probably like your main thing. Maybe low sodium to keep fluid out of here. Because remember, your fluid attracts water. Patient teaching, maybe just move head slowly to prevent worsening of vertigo. So that's your dizziness again. Low sodium again. Avoid smoking. Remember smoking. Um, smoking can make you dizzy as well. Just it constricts as well. So less blood flow to the ear as well. Avoid caffeine. Avoid endangering self, I guess, and endangering self with fall. So like don't stand on chairs or stools or ladders. you know, keep them away from falls, basically. That's your big picture idea here. Any questions before we move on to eyes? And I think for your eye stuff, I just presumed we were gonna run out of time, so a lot of it is just filled out, and I'm just gonna talk about it. But you guys
Bruh.
can ask questions. Do you want me to unfill it out so you guys can interact? I don't think so. So we're just gonna do it that way, I think. Yeah. Any questions at all on anything we've talked about so far? Yeah. I would like to interact more, but time is of the essence. Honestly, we're actually doing pretty good on time regardless, but okay. So I kind of have like a general section on glaucoma. So you have definition of glaucoma is kind of like a group of eye disorders resulting in increased intraocular pressure. So increased pressure in the eyes, which can lead to ischemia. So anytime there's too much pressure going on, you have intracranial pressure, too much pressure in the head. It's going to lead to ischemia in the brain. Too much pressure um, and stuff going on in your heart, it's going to lead to ischemia of the heart. Here, too much pressure in the eyes can lead to ischemia of the eye, so that can cause eye damage. There's two types, or two main types that they go over. Open closure and sorry, angle, things like open angle and closed angle. Your closed angle glaucoma, angle closure glaucoma, this one's your medical emergency. This one can have permanent vision loss. And I have like a nice picture here for that. So here's like a little table so you guys can have like a compare and contrast going on. I kind of wrote down some of the risk factors you'll see here. So diabetes, family history, hypertension. Again, your diabetes is like a major risk factor. So, the usual suspects. Um, Again, here you have some of the signs and symptoms we'll talk about a bit, or I guess I guess it's all here. So I'm like, it's all here. Let me see. The pathophysiology behind open angle and angle closure glaucoma, you don't really need to know. I have a picture for it, but maybe you just take a look at it real quick and then I'll delete it so it doesn't confuse you guys. But basically here you see the normal eye. With glaucoma, you're going to have increased pressure in the eye. That's what all these arrows are pointing at. You have extra pressure going on. You can have pinching of that optic nerve. So that's where the vision loss can come from. Here with the open angle glaucoma, here you can kind of see generally the eye has kind of like a drainage canal where your kind of little fluid kind of runs through. With your open angle glaucoma, it's kind of an obstruction by something, as you can see, like the little network here that allows it to kind of cycle through is obstructed. But with your angle closure glaucoma, you kind of have instead of being obstructed by something, it's kind of like your own eye is obstructing the drainage. The pressure of the glaucoma is causing um, the impaired draining. Again, extra info, you don't need to know it, but that's just kind of the quick and dirty pathophysiology. Yeah. This one's going to be more dangerous because it's kind of like the pressure's so big that it's your own eye pushing against itself. Extra pressure here, it's just caused. It can be caused by something blocking the meshwork, and there's more information on that, but you don't need to know it. Your main focus is kind of understanding the big picture. So what is your big picture with your glaucoma is that you're gonna have um, a loss of your field of vision. So you will see peripheral vision loss. So that's the key thing with this one. It's peripheral vision loss. There's going to be another one down the line that's central vision loss. So you just got to make sure you don't confuse them. So glaucoma is peripheral vision loss. So I'll kind of write those down here. So it's peripheral vision loss. So what does that look like? So peripheral vision loss. So let's see if we can get a good picture of it. I think the picture in your PowerPoint is actually pretty good, but this one's really good as well. You can see how you still have that. Yeah, it's like a tunnel vision. Yeah, the macular degeneration is the loss of the center. Your tunnel vision here. So quite literally, it's the sides are not able to be seen. So something you can do to assess for this would be kind of like having the patient kind of look straight, and then you put like fingers to their peripheral and have them and then ask them how many fingers you're holding just from looking at their peripheral, just from their peripheral vision. This one you get halos around the lights. Yes, so here, as you can see from the little chart here, you can see halos and you can lose peripheral vision. So let's look at what an open angle glaucoma looks like. So here you, again, you kind of see, um, let's see if we can get some halos going. So that's kind of a difference between a glare and a halo. So be careful on the wording on that. I think maybe one of your questions, Kaylin, had something about glare versus halo, or am I misremembering? Are you AFK, Kaylin? Oh, she's writing. Okay. Yeah, Kaylin's writing down. Oh, I asked, I think one of your questions, for this had like they try to catch you on the difference. Oh, okay. I was like, what? You found it? Oh, it was about cataracts, but that's kind of like that the halos is associated um more with your glaucoma. Here's an example of like the halos. Maybe I can put this picture in. So let's see. It's a big picture, so I'll make it smaller. And the peripheral vision loss, the one we found before, is really good. This one's good too, actually. So hopefully that paints the picture. Um, One of your big things with closed angle versus open angle is that with closed angle, you will have sudden severe eye pain. Think of it like an eye, like your eye having a heart attack, like an eye version of a heart attack, right? Remember that it's complete closure of, where did that picture go? Oh, I guess I took that picture away because I said we didn't need it, but I guess we're gonna use it just as a reference again. Remember here that here you have like, you can think of open angle glaucoma like the eye version of atherosclerosis. Your canal is blocked by stuff, but you're still able to still have some drainage going on. And you think of your angle closure glaucoma like a heart attack, like MI. You have, it's completely cluttered off, it's completely occluded. So kind of like your MI, you have pain of your heart, you have that chest pain, but with this, you're gonna have eye pain. Does that make sense? Does that make it more relatable or understandable on that? Anyone? Fellows? Yeah. Do you guys want me to keep this picture in or nah? I don't want to make it too much info. I don't know if it helps you. Kind of like open angle is like atherosclerosis, and angle closure is like an eye version of an MI. That's why you have that severe pain going on. Okay, cool beans. But yeah, that's kind of like the main difference. Your open angle can also be like asymptomatic initially. You can have that high pressure, or higher pressure, consistent higher pressure without the without some of the symptoms until it starts progressing, and it's kind of like a progression over time, um, gradual loss of vision, gradual stuff like that. While your angle closure, you're just kind of having a nice day, and then all of a sudden it kind of like eye pain, and you start having a loss of peripheral vision, nausea, vomiting. That's something that you'll see with intraocular pressure. So it's what's it called, IOP. So the word IOP is similar enough to ICP, and both of them have nausea, vomiting. So that's kind of how I think about it. And I don't know if anyone wears contacts, but I've actually had nausea, I've had nausea from putting in my contacts a little bit off, and it was like putting extra pressure on my eye, and I was feeling nauseous from my contact being on my eye. So I kind of relate to that symptom. So in my brain, it makes sense. Um, so some of the diagnostics they do, if you guys have gone to the eye doctor to get like your vision test, they'll do like the little puff test. I don't think I wrote too much about it because I don't think that's the focus. But yeah, that's the little puff test they do. Um, they also do like a pressure test. Oh, I guess that is the pressure test, but your glaucoma will show like an elevated pressure of your eye, which makes sense because that's kind of like the whole condition. It's basically glaucoma is like eye hypertension. Open angle glaucoma is your atherosclerosis, and your angle closure is your MI, but eye. Oh wait, hold on. Atherosclerosis. MI. All right, I'm a genius. All right, let's see. Let's move on. The management for it. You can take um like eye drops for it. So let's see if I can get one that's specifically for this. I think rainbow. This one also. I'll put all the symptoms here, like rainbow around lights and stuff. Red eyes. Call it a foggy cornea. Not to be confused with like cataracts. So I'll have a picture for cataracts versus glaucoma. I'm sure you guys are tired, so I'll try to get you guys out of here as soon as possible. Yeah, there's eye drops, and the eye drops are beta blockers, I think. Let me double check on that actually. That would make sense to me, though.
It's the Timolol, no?
Yeah, Timolol. There's like a few. I'm trying to remember how hard they went on the meds. I don't think it was too hard, but if it's in your study guide, I would know it. Okay, so then in that case, you gotta know it. Yeah, so we'll go over those. So your eye drops, and something I definitely think you guys should know with your eye drops is making sure how to administer them. I have a video. I think it's Nurcera. Yeah, it's Nurcera. How to administer eye drops. So like your key thing with your eye drops is making sure the tip of the eye drop doesn't touch the eye, asepsis and whatever. You also want to make sure that it's actually uh, it's actually meant to be put inside like the little pocket. Like if you grab your little eyelid and pull out. It's like a little pocket. It's meant to go inside of there, not actually like directly on your eye. You can apply some pressure, so that's there to keep it from kind of having like a systemic effect, kind of just going into your eye, because it's still a beta blocker. So like your main one, timolol. So you don't want it having a systemic effect, because if, let's say, someone with normal blood pressure gets a beta blocker, it might drop them too low, or like has that systemic effect. So that's why you got to be careful with the eye drops. So the beta blocker, this one's timolol. So you want to hold for, and low BP or heart rate. You guys should know um the ranges by now for when to hold. Again, this is if it ends up becoming like having systemic effects. It's contraindicated for those with asthma for the same reason a lot of the beta blockers are, because it causes bronchoconstriction. Yeah, and just put some pressure under the eyes, which is what we talked about. So then some of the other ones they have let's see, Aesopt, I think is one. Yeah, Aesopt. I will put both the brand name and the generic name. Brinzolamide, aka Aesopt. It's an amide, so I think the obvious one is assess for allergies to sulfa medications. So you might see in the chart, it just says allergy sulfa. So that's any medication that can be considered a sulfa medication. So anything that has the word like sulfa in it. And then this one, this one, I guess, just can't really tell too much from the name, but this one's a sulfa med. So any allergies to sulfas you want to not give. Other thing that has to do with it apparently has a diuretic effect. And then there's cholinergics. Just like how this blocks sympathetic, this affects parasympathetic, so they both have the same effect to stimulate the parasympathetic nervous system. So this is your pilocarpine. I think the generic name is Pilocar. Yeah, Pilocar. And it's a pupil constrictor. And it's a cholinergic, so you want to think about your cholinergic side effects. So you can't see, can't shit, can't spit, whatever the other ones are, can't pee. So like blurry vision from kind of going too much the other way. Urinary bowel retention, dry mouth. Similar thing, it can cause bradycardia and hypotension. Yeah, no night driving. Makes sense. Okay, so I guess you guys had to know the eye drops. Alrighty then. There's a surgery for it. Were you guys told you need to know it? No? Cool. So how long do they need to take these eye drops for? Few months, few weeks? Yeah, forever. Oops. Patient will need to take them forever. Yeah, I love that one. Forever. Yeah, just if you see like a question where it's like, oh, I'm so glad I only need to take these eye drops for a week, or something, and then you know that you got to educate them on their eye drops. They should be getting eye exams as well. So they should get eye exams. That's a good one. Like wait a few minutes before. Forever. Sure. I don't know, is there? Let's see. In between. Oh, cool. Patient education, kind of goes on like getting eye exams and stuff. There's like a specific chart. I don't think you really need to know it. Probably. Just kind of know that they need to get eye exams, but just in case, I will include it. Here's the list that they gave. So it seems like it's more, you have to do it more often if you are, as you get older, you do it more often. So I guess like every 2 to 4 years when before you're 40, and then after that, it's like pretty much yearly. You want to avoid things that have cause increased intraocular pressure, so like straining, avoid straining. Only other thing is that when it comes to your angle closure, they specifically give IV mannitol to decrease IOP. So just like how your IV mannitol is good for your ICP, it seems to be also pretty good for that intraocular pressure. Okay. Yeah, other than that, we have all this information here as well. There's some surgeries for it, but I don't think that's a focus. See if I can get you guys out of here soon. For cataracts, I had a picture here. Boom. Kind of like a look at what cataracts versus glaucoma can look like. So with cataracts, you kind of have something on top that's preventing you from seeing cloudy lens going on, like a cloudy gray lens. Your glaucoma can also have a little bit of little fogginess in there, but the characteristic of cataracts is going to be like that foggy, cloudy lens. Let's see what else we got. Yeah, I have this chart for you guys. So the main cause of it is aging. Like the main risk factor of it is aging. So as you age, you have a higher risk for developing cataracts. The usual suspect, diabetes, is always there. Some drugs that can cause it, corticosteroids in general, like smoking, another usual suspect. Your main thing is going to be that cloudy lens. You're not going to have pain or anything, but you'll have um like blurry vision at first and then abnormal color perception. Something that I think I've seen on Kaplan is like you'll be lacking the red reflex, meaning um but like with like the photographs. Uh I think let's see what that looks like actually. It's interesting. But I think this one's actually for comparison to something. Or am I misremembering? Yeah, it's a lack of red reflex. Sorry, this is because the red reflex was meant to be here. The red eyes, that's the red reflex. I think with glaucoma you'll have the red reflex, so kind of like the cats. In pictures you'll see like the red eyes. I don't remember the reason for it, but here you can see he has the red reflex on one of the eyes. So maybe there's something to look into for his eye there. Um, like that. Like that. You can see a bunch of red eyes there. So that's like something to do with glaucoma. Um, common for both. Both in terms of what? So that was the thing that I was saying is that glaucoma has the red reflex. Um, cataracts does not. So here again, like the thing with it is like I was saying that there can like visually they can look similar. Here you can kind of see they look similar, but the cataracts will not have a red reflex. So that's like but glaucoma does. Okay. Oh no, that's my bad. I jumped around a little bit. This is mainly treated through surgery. So here, like I have like the pre-op teaching and stuff. Someone already mentioned, I think someone mentioned antibiotics already. I feel like they did, or maybe I'm just hallucinating, but you can have like topical antibiotic cream to prevent infection, eye drops to dilate pupil. Other than that, it's just like the usual stuff that's pre-op, typical pre-op teaching or typical pre-op stuff, informed consent, whatever. For the post-op, they're gonna need to be taking eye drops, maybe like an eye shield, steroids to reduce inflammation, avoid activities that increase intraocular pressure. I have a list of things that they should avoid while recovering. So these are the things they cannot do. No bending, heavy lifting, try to avoid sneezing and coughing, blowing your nose, try to avoid vomiting, straining, sex, want to use stool softeners because that helps reduce straining. No tight collars on them. And you want to educate them on report to MD. If there's green, yellow discharge on the eyes. Oops. So that's can be a sign of infection. Yeah, sun pain, worsening vision, swelling. What about reading? Yeah, pretty much like worsening vision, reading. That kind of goes with that. Oh, you mean for activities? Probably, if I had to guess, probably avoid reading in the dark, but maybe
I
reading
think
in
it
the
was also during recovery.
okay. So avoid reading. Well,
Heh.
that's good. I don't read anyway. Okay. Okay, any questions? Anything extra you were curious about?
Diego, why the tight collar? Avoid the tight collar.
I believe the idea, and it's actually applies similarly to your um ICP, is that the tight collars you have most of your circulation around that area, your jugular and your carotids are there. So having a tight collar can cause um constriction there, and I think that has an effect on like ICP, and it has an effect on your intraocular pressure. Because again, that's where that area is where your blood flow is going. Like um that's where your biggest sources of blood back and forth from the heart into the body come from. So I think that's the general idea behind it.
Thank you.
Hmm. Is this one the glare vision? Yes, this one's the glare vision. So I kind of have it here um in the manifestations. The person says, I see glares. You have the cloudy lens. Halos is more glaucoma, so that's kind of the main things there. Okay. And then finally, I think, well, there's two more things. Okay. Oh, this one's long too. I'll try to finish by three. Macular degeneration. So this one, as opposed to your glaucoma, which has peripheral vision loss, this one has central vision loss. And this one's more caused to the age, so it's age related. Here's just like a picture that I think that was in your PowerPoint. You can kind of see that kind of progression of the condition. You literally, it's like you have a hole in the center. Did she tell you guys that anything about the dry versus wet degeneration? Our class was told we didn't need to know it, but in case you do for some reason, this chart differentiates them. All right, perfect. Yeah, our class didn't need to know it either, so that's good. I think your main focus on understanding this is just knowing that one of your biggest factors is like age. So not really risk factors, but your biggest thing that causes it is age. Age is your um, age related. It's related to aging. So it's not like if you have a question where the patient's like, well, why is this happening? It's just kind of like it's age related, but there is risk factors involved, like your typical suspects, smoking, hypertension, family history. Women are more likely to have it for, I'm not really sure the reason, honestly, but that is something that was mentioned there. Um, yeah, kind of like your race can matter. African American or Hispanics, higher risk of developing hypertension, and hypertension is one of your risk factors for it. So it's just things to keep in mind. Again, just kind of like the other ones, things that impact your blood flow is going to impact your intraocular pressure and stuff. Some of the treatment here, just real quick, like antioxidants. Our class didn't really get much detail on it. I don't think yours did either. I'm pretty sure they're using the same PowerPoints. Antioxidants, vitamin B12, we remember, can be used for um, functioning of nerves, and this is degeneration of, I think, your optic nerve, or like part of your, well, actually, it's the generation of like this part of the eye here that leads to that. As you can see here, you can kind of see that. But yeah, in terms of your treatment, that's some of the things they mention. Vitamin A derivatives, but all they do is decrease progression. They don't really stop it. Um, Again, I don't think there was too much on this one. This one was, I think, maybe less important than the other ones. I'm not sure what your study guide says though, but I don't have too much information on this. Just do not drive. I think if your vision was looking like this, it'd be a good idea not to drive. Stop smoking. Manage your hypertension. That's one of your main risk factors. Well, these are your two main risk factors. place stuff to the side. So if someone has macular degeneration, maybe you'll get a question like patient has macular degeneration. What's something to stop your CNA from doing, or like when do you intervene if your CNA does blank? And maybe it's because they're putting everything in front of them, in front of the patient instead of to their sides. So that's where you would intervene with the CNA and let them know that the patient has trouble seeing in front of them, has trouble seeing. Um, they can only really use their peripheral vision. So things like that. Okay. And then finally, lastly, we're at retinal detachment. This is a medical emergency. It sounds bad, and that's because it is bad. Having a retina be detached sounds really bad, and that's because it is. So again, another little table for you guys. I think the main thing here to think about is the fact that you have like that curtain vision. So here's a picture from the PowerPoint. It literally looks like someone like took your like it literally took like Photoshop and edited your picture away. Actually, I see a mouse there, so maybe that's what happened. But that's kind of like the idea. Here's another picture that kind of shows um like part of your like visual field being missing. It starts out kind of like blurry vision. It's painful, as you can maybe imagine from having your retinas detached. You'll see dark spots or floaters. So this one picture kind of has everything. It has the curtain over the field of vision. It has the floaters there. It's kind of like blurry vision and stuff. Bright flashes of light. That's another one. That's kind of shown in the first picture. This picture kind of has it all. It has the floaters, has the curtain vision here. It has the flashes of light. So then how do we manage it? The only real thing we can do is to go to surgery, and it's called sclerobuckling. I don't think you need to know the name. You just need to know that it's a surgery, and you need to get them to surgery. It's a medical emergency. Oh, it says painful or painless? Blah blah blah. Oh, I meant painless. Never mind. I guess it's painless. My bad. I'm sorry. I misread it. I'm surprised it doesn't hurt actually. Yeah, so let me backtrack on that. I misread it. So some of the stuff they do pre-op, they'll dilate your pupils so they can kind of get a better idea of what's going on. Post-op, they will give you an eye patch, an eye shield just to protect the eye, tell you to minimize the movement. Um, you will do the pupil response. You want to assess how the eye is doing after the surgery. Makes sense. After surgery, you assess them. After surgery, you um, protect the part that just got operated on, aka here the eye. What to report? You're going to report sudden loss of vision. You're going to record eye pain. Um, if their pupil doesn't have a normal pupil response, we're going to worry about that. And kind of like the other one, avoid anything that increases your intraocular pressure. Don't rub your eyes, anything that includes straining. The only painful one is closed angle glaucoma. Let's see if that holds up. Painless, okay. This one is also painless. Doesn't really have anything to do with the pain in terms of that. Let's see. Cataracts doesn't hurt. We know angle closure for sure hurts, and the other one's asymptomatic. And that's, yeah, you're right. That's pretty much the only one. Yeah, your closed angle is the only one that hurts out of the ones we know. Cool beans. That's all I got. Does anyone have any question on anything? I have like let's see. I have like a list of Quizlets that I guess we use to study. Again, like I always tell you guys, Quizlets are good. Like just Google Quizlet and stuff. So if you guys have Um, you guys have like any topic that you're specifically kind of stressing about? Maybe, like I said, always just like Google Quizlet and then go Quizlet, meningitis, Quizlet, glaucoma. That can help. So here's like a link to some. So here is our girl registered nurse Sarah, RN, on glaucoma. There's one on GBS. I don't think GBS is as much like, and that's like a big picture thing, but I have some from nurse Sarah. Um, but just always like extra stuff that can be good from our girl. Let me get her meningitis one. Ba, 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 ba. Does she have one? I guess I don't really see it. But yeah, just look around. There's always Quizlets on stuff. There's always Nurse Sarah, simple nursing. There's Nurse Labs. Yeah, just try to find questions you can, as much as you can, to always practice. Yeah, any other questions and stuff? Otherwise, I'll stop the screen share. Get you guys the PDF.
I do have a question.
Yeah,
For PDs, do we need to know the medication and the doses of them?
for let's see, for which one specifically, or just in general?
For like the chlamydia and gonorrhea, the medications?
I'm trying to remember. I feel like dosing, not so much, but maybe the meds. But dosing, I don't think as much. I don't believe. Because I know Miss Orozco likes her meds. She did teach farm. So she does like her meds. I don't recall. If I'm being honest, I don't recall. I would say I would say know the meds, recognize their names, but I think the dosage not as much of a focus. Okay.
Thank you.
Any other questions? I'm gonna give you guys the PDF right now. Neuro outline the diff. As soon as it uploads, it's a big one. Another big file. When's your guys' test? Is it in the morning? In the morning. All right, mine. I think ours is also at 8, or is it at 9? I don't know. Actually, I
It's
actually
at
don't know
8
where.
for us.
Oh, it's at 8. I was gonna say I don't even know when our final is. Let's see. Bet. I believe it's online, right?
Yeah.
Yeah. All right. Yeah, 8 a.m. online. Once we're done with that's our last lecture final for me and Kaylin. That's our very last lecture final. And I think we have one more Kaplan final in 242, and that's it. Just NCLEX, and it's over. It's all over. How do I feel? I kind of just want to get it over. I'm kind of burnt out. Yeah, Kaylin and I have a really good buffer for our grades, so like we don't really have I don't think we're worried too much about that and on that front. But it's just kind of like getting it over with. Yeah, I'm just tired. Yep. Just kind of like getting through the final, then just I think I'll stop being worried once I do my first preceptorship um shift, just to see like if I got if my person is cool, and then I'll chill out from that point on. But yeah, you guys are halfway there, ish. Yeah. All right. Good luck on your test.
I was gonna say you might want to mention I got a message from Diane. She was like, "Wait, we don't have you guys anymore." We're still doing tutoring for 222 for you guys.
Oh yeah, we're still
I felt
doing
like
two.
that was maybe we should have said that.
Uh, yeah. We'll still do 222 once you guys go into third semester. I plan on coming back to do third and fourth, and then I'll try to come back another semester to just focus on fourth semester. So I'll try to have you guys the whole time.
Yo, that
Cause
would be
yeah,
legit though.
cause I want to do education, so uh I think it makes sense for me to have uh like PR not PRN, I guess, like do my own hour shifts working for the school still, just to keep up um connections and stuff.
Yeah.
Yeah, so I think that'd be good. I will say I'll probably struggle a little bit with OB because I don't remember much. So
That's okay.
I'll have to do more research on all the stuff before we go over it.
If I recall, Bella wanted to do L&D, like she really liked that rotation in
Hmm.
222. So, she'll be probably more a little bit more helpful than we might be. I'll take some time to look stuff up, but it takes me a little bit to remember just because it's been a whole year since we took it.
Yeah. I will say I actually did like OB. Eventually it grew on me. I still don't like peds, but um
Okay.
we're gonna have to like study it anyways for the NCLEX, so it's still gonna help. It should be good still.
Yeah. Oh, you're still recording as well.
Oh really? Oh my bad.
Yeah. It says recording at the